So our first speaker is going to talk to us about a model for change in providing feedback for physicians. Jocelyn Lockyer, as you know, is the Senior Associate Dean for the University of Calgary and was previously introduced. The only thing that's changed is she now has one more invited presentation on her CV. Jocelyn.
Thanks very much. So I am going to talk about the R2-C2 model. I do need to back up a bit, though, before I get there. And in talking about this model, which we're still testing and hoping to get some more grants to test further, I really have to acknowledge the leadership in this project of Joan Sargent at Dalhousie in Nova Scotia, who was supported not only by myself as a bit player, but also by Karen Mann at Dalhousie, Tim Dornan at Maastricht, Kees van der Vleuten at Maastricht, and Eric Holmboe, Philadelphia, and others along the way. So it's very much a group work. The R2-C2 stands for rapport, reaction, content, and coaching. But before we get there, just to remind you, as Dr. Doherty did earlier, how a physician practices, how well they do is very much a function of so many things, including the education they've received, the kind of setting they're in, the kind of patients they see, how often they see those patients, how often they do those procedures, the resources available to them, including the technology and their ability to use that technology, as well as that larger system environment, which may or may not make things possible for patients, including access to hip surgery in a quick way. So it's not surprising then that physicians are in an environment where it's hard to do well. There's many things that affect how well they do, but physicians, like all people, don't assess themselves well. Most of us don't have very easy ways to calibrate ourselves. And in fact, there's lots of good reasons why we don't. There's some ego protection, and we know none of us go to work intending to mess up on a daily basis, but stuff happens, right? When we've looked at our multi-source feedback data, looked at how physicians self-assess versus the ratings of their received from their colleagues, it was pretty much a flat line. Most physicians rated themselves as average, regardless of whether they were above or below average. That got a number of us thinking, and this was a project led by Joan Sargent, which actually was funded by Ian Bomer, Medical Council of Canada. But what we did was we did focus groups with undergraduates, residents, and practicing physicians in 5 different countries. And we said, you know, you're all getting data. How are you assessing yourself? How are you using that data to inform yourself? From those focus groups, we came up with this diagram, which really was people were getting information. They were getting it from a variety of sources, from patients, from professors, from preceptors, from their colleagues. They were getting internal stuff. Well, I think I'm doing okay. I don't think I'm doing so good, or that went badly. They were interpreting that data, and in interpreting it, they were reflecting, they were comparing it, they were trying to figure out comparators, they were filtering it. Oh yeah, but he's a jerk, how would he know how I'm doing? Right. And they were responding to that data by accepting it, seeking out confirmatory knowledge, acting upon it, but in some cases ignoring it and rejecting it. And what we also found that there were many things that also influenced the acceptance and uptake of that feedback, including the environment, the learning conditions, how easy it was to make changes, but also tensions, because sometimes they were getting feedback from people that they didn't trust or that they trusted. And it made a big difference into how, whether that data was ignored or not. We then said, okay, well, that's for the whole group. What happens if we strictly look at just the physician data, so only the physicians? And in this study, we had all of the physicians were getting data. They were getting either PAR data, they were getting data from the American Board of Internal Medicine, which included both chart as well as patient feedback. And so they had, let me see if I can work this. I think I spend more time trying to work this. Anyway, forget that. On the right side, physicians did have data from surveys, from audits, patients. But on the left side, they also had standards that they knew about. And so we were trying to get them to think about how they were using those standards, whether they came out of clinical practice guidelines as comparators, the evidence-based literature, or patient information. And we said, okay, well, what's going on? And what physicians were saying was, I get this data, and I use it to validate my practice. You know, I'm doing okay. Sometimes it triggers changes, and sometimes I just question the data. It just doesn't make sense to me. I can't use it. As our group pondered it, we recognized that physicians were getting lots of data from lots of sources, often very difficult to make sense of it. There was also great variability in what physicians saw as the standards, in the data quality, and even in the frequency with which physicians got data on which to act upon. But by and large, for most physicians, and this was physicians in Canada and the United States, it wasn't part of their routine or regular practice. So it's really hard to use feedback if it's not given routinely and systematically. And it may not even be stuff you're looking for. We started to look further at the literature on feedback and recognized that, yes, feedback can have a powerful effect on learning, but the leaders and gurus said, yeah, but it can't be about you. It has to be about a task. So you're not doing the task well, but it's not because you can't learn it. It's because you aren't doing the task. So, but we also found out from that literature that coaching could be used to help people identify their strengths and weaknesses, but coaching had to be a sequential process. You can't just tell people or send a message out once and expect that people would pick up on it. And certainly, as was mentioned earlier, from the audit studies and the work on audits, audit works with feedback works best when people aren't doing well, but seems to be helpful to be delivered by a supervisor or a colleague, provided more than once, both written and verbally, with clear targets. But it's going to be influenced very much by that whole myriad of factors we talked about that influence performance. So the challenge then is, how do we deliver feedback? And you know, when you think about the task, it's quite daunting. We have 60,000 physicians in our country. In Canada, you have thousands as well. So how do you systematically deliver feedback and routinize it? And so that's why we're probably all at the stage of, well, we can figure out ways now to assess physicians. Multi-source feedback is relatively easy to be routinized and funded, but then going to the next level of audit and looking at clinical practice and then saying, well, how do we deliver feedback? It all becomes a bit daunting when the resources are limited. And particularly when we know that sending somebody a report card is not likely to get us very far. And the literature now, you know, and we know also that a reflective conversation with the physician is going to be required. People can't join the dots easily. So people need help to understand and use the data. As our group pondered this, we said, hey, you know, there's some clues from the literature and the research, from our own work on self-assessment, which we've now termed informed self-assessment, because you can gaze at your navel till the cows come home. It's a terrible expression, isn't it? You can gaze at your navel, you can think internally, but if you don't get feedback that's informed by something, it's not going to take you very far. So what we need to do is to help that physician understand, assimilate, and use the external data. So that was one of the 3 key pieces in our 3-legged stool that led us to the R2C2 model. That whatever we did had to be person-centered. You had to take the data from something that blitzes out to the doctor or the doctor's told to one where the physician makes it his or her own. And then you really have to go the next step, which is helping the physicians use the data. And we've all heard of the feedback sandwich, good, bad, good. But in fact, the problem with that feedback sandwich is it doesn't help the physician get better. It doesn't help the physician address where they need to be next. It simply tells them some stuff. And really what we need to be doing is helping the physician identify, help figure out how they can make the change, what resources they're going to use, what timeline they're going to do it in, and then capture a sense of success. What does success look like? And from that, our R2C2 model was born, and the letters stand for rapport building, exploring reactions, exploring content, and coaching for change. So to elaborate, I'm going to go to this one next. So in this model, and it's only been tested where the physician has data, so whether it's data from the multi-source feedback, American Board of Internal Medicine, or some other place where they have written feedback. And the discussion will proceed through 4 stages in a very iterative way in which the person starts initially by building rapport, finding out about that physician and their practice. We're assuming that the facilitator won't be a partner in the practice, but would be a colleague, would be in the same discipline roughly, would be a physician. So knowing something about the physician, their context, and their work, their patients. And then asking about that data. What did they figure out from the data? What were their reactions to the data? Is the data consistent with what they believe was happening? Were they surprised by any of the elements? From there, it's focusing on the content. And not just the bad bits, but also the good bits, right? Really exploring with that physician, what is the content that they found in this report? What sense have they made of it? Does it work for them? But being very explicit in a step-by-step way to look at the nuances of it. And then finally, the coaching for change part, where you really help that physician draw on the data and come up with an action plan and a commitment to make some changes. The model has been tested. We worked first with a groups of family physicians to make sure it made sense. Worked with the College of Physicians and Surgeons of Ontario and the American Board of Internal Medicine, who were very gracious. In fact, I've got a video, some videos that the ABIM allowed us to have that I can use for teaching. A College of Physicians and Surgeons, we have transcripts of this working with them. And then from there, trained other facilitators to deliver the model. And then as we analyzed the data, tried to make sure it made sense and to come up with some of the expressions that you would use with such a model to make sure to really, I would call it clinch the deal, right? If you were in sales, you'd call it clinching the deal. So 4 stages, being tested, rapport building, exploring reactions, exploring the content, but then finally coaching for change. We believe it shows promise in several different settings where physicians do get a report or data, that facilitators can be trained to deliver the model. We've got about a 2-hour training program. Mind you, all of those facilitators had been engaged in providing some kind of feedback before, but what we don't know is whether it can be rolled out on a broader scale with, and used with physicians who aren't volunteers, because the physicians we worked with initially have all been pretty high performers. Otherwise, you'd never agree to be videotaped, right? And then the next stage, of course, is, okay, so the physicians promised, they made a commitment, but did they really follow through on it? Were they able to do what they thought they'd do? So there's still lots of testing and work. I think in terms of revalidation, some of the meaning that we've got from this is that external feedback is important. If physicians are going to be informed about their self-assessment, they do need external data. Au naturel, we know from multi-source feedback, physicians will use the feedback data to some extent, but they probably need assistance to get it over the goal line. And in that, they need help to understand what their data is all about, to reflect on it, to develop a realistic action plan that they can actually implement, that they can commit to, and then there be some way of monitoring this. I think for people involved in this work, though, it is costly. It needs an infrastructure, it needs a buy-in from the physicians. Physicians have to agree that someone is going to sit down with them. I think we're talking partnerships. This is too big for any one organization. I talked this morning about the physician learning program, and that is certainly an example of where 5 or 6 organizations have come together. The question then comes is, does everybody need a facilitator or a coach? The answer is probably yes, but how do you do that? Sir Peter Rubin can talk to you probably about the appraisers and their role and how effective that is. A less expensive model that's just appeared in the literature, it comes from the American Board of Internal Medicine, where they actually created a script. So as a physician, you would sit down with a peer and have a script that would ask many of the questions that would be in the R2C2 model. And you'd do that with a peer. And you'd write down the answers and submit them and review them in 3 months or 6 months. There may be some potential there because I really can't get my mind around how we fund one visit for all, but the British have, so maybe the rest of us can too. So a large team that worked together to pull this off from Maastricht, American Board of Internal Medicine, Universities of Calgary and Dalhousie. So working together with significant funding from a number of organizations.